Hello everyone in CardioMinds channel and welcome to the fourth video in the guidelines of infective endocarditis, and today we are dealing with the question when to schedule this patient for surgery and what are the common complications of infective endocarditis. Of course, in these circumstances that we are facing nowadays, reminding myself and reminding you with the struggle of our Palestinian brothers against the Zionist entity, so should support them, pray for them, and donate for the injured and all the victims of the Israeli occupation. In our video today, we are going to speak about the indications of surgery, what are the neurological complications that infective endocarditis patients can face, the use of antithrombotic therapy for infective endocarditis, the splenic complication, osteoarticular complications, conduction disturbance, and some of the surgical principles related to the valve surgery in those patients. Let's start with the indications of surgery. Of course, we divide the surgery according to their urgency into emergency surgery that should be done within 24 hours for life-saving, urgent surgery within 3 to 5 days, so they are not as urgent as the first type, but they should be done within few days in order not to increase morbidity or mortality, or non-urgent surgery, which don't have the same urgency as the first two types, but it should be done within the same hospital admission before discharge. Heart failure is the most common complication and the most common indication for surgery in infective endocarditis. Its symptoms may vary from mild dyspnea to orthopnea up to acute pulmonary edema or cardiogenic shock due to severe compromisation of the valvular function. Of course, if it is right-sided, so it would be present with right-sided heart failure. New onset heart failure sometimes is the predominant clinical presentation or the initial presentation in the majority of patients, but sometimes it is just worsening of pre-existing heart failure. And of course, the in-hospital mortality increases with the severity of the heart failure presentation, and so the survival benefit of surgical treatment versus conservative medical treatment is mostly apparent in those with NIHA class 3 to 4. So what are the risk factors that increase the patient liability to develop heart failure? Of course, the older age and multiple comorbidities and the presence of aortic valve affection increase the liability of the patient to develop heart failure, because aortic valve here is at the outflow of the left ventricle, so more common than the mitral to cause heart failure. What are the causes of heart failure in infective endocarditis patients? The most common cause is leaflet perforation or sometimes mitral valve cord rupture, resulting in new severe valvular regurgitation or worsening of pre-existing regurgitation. Sometimes development of intracardiac fistula, like for example ventricular septal rupture, the same as it develops in acute myocardial infarction, but here it is resulting from necrosis due to the extension of infection and resulting in volume overload on the left ventricle. Or the size of the vegetation interfere with the leaflet opening, resulting in stenosis or even obstruction to the valve. Or sometimes the vegetation itself interferes with the coaptation of the valve, resulting in regurgitation. And less common that the vegetation may result into coronary embolism, resulting in acute myocardial infarction. Patients with infective endocarditis and heart failure usually show in the imaging lower LV ejection fraction due to the volume overload and larger vegetation size. Perivalvular abscess may develop due to the local extension of the infection, pseudoaneurysm, and valvular regurgitation due to leaflet perforation or cord rupture. So the recommendation in the guidelines that emergency surgery has a class 1 indication in aortic or mitral, native or prosthetic valvular endocarditis with severe acute regurgitation, obstruction, fistula causing refractory pulmonary edema or cardiogenic shock. Of course, it makes sense that patient with pulmonary edema or cardiogenic shock, he could die in less than 24 hours or even few hours. So we should go for emergent surgery. And urgent as a class 1 in case of severe acute regurgitation or obstruction causing symptoms of heart failure or echocardiographic signs of poor hemodynamic tolerance like impaired ejection fraction, dilated LV or RV, dimensions, so we should go with the surgery within 3 to 5 days. Of course, the timing of the surgery in those patients complicated by heart failure should be decided by the endocarditis team, but please without delay, because in some cases the patient case is very critical, and so emergent surgery should be decided without waiting for the discussion of the endocarditis team. The second most common complication is the uncontrolled infection, and the second most frequent indication for surgery is that the infection is not resolving. Considered to be present when there is persistent infection or sepsis despite antibiotic therapy, as blood cultures remain positive for more than 1 week, or persistent sepsis despite appropriate antibiotics when other causes of bacteremia have been excluded, or signs of local infection within the heart that do not respond to antibiotic, like increasing vegetation size. This is a poor sign of lack of response. Abscess formation, and of course we know that abscess usually does not respond to antibiotics due to presence of biogenic membrane, development of pseudoaneurysm, intracardiac fistula, or new AV block due to the local spread of infection to the region of AV node or His bundle. And of course, perivalvular and abscess formation are more frequent in aortic valves than mitral valve endocarditis, and in prostatic more common than native valve endocarditis. And the last reason, infection with resistant or virulent organism like fungi, MRSA, vancomycin-resistant enterococci, non-Hasig gram-negative bacteria, or Staph aureus. All of these are very virulent and resistant organisms that usually do not respond to antibiotics and may result in uncontrolled infection. Some patients even may develop septic shock, as they require vasopressor infusion to maintain mean arterial pressure of 65 mm mercury or more, and the serum lactic acid is usually greater than 2 millimole per liter in the absence of hypovolemia. It may occur in 5 to 10% of patients, and usually the risk factors include virulent organism like Staph aureus or gram-negative bacteria, as we mentioned before, persistent bacteremia in the follow-up culture, nosocomial acquisition of infection more liable than the community acquired to develop septic shock, acute kidney injury or diabetes mellitus worsens the immune status of the patient, CNS emboli, large vegetation. Of course, all of these factors may result in septic shock, and in this case, surgery is essential in order to have a significant reduction in the early and 1-year mortality for patients with infective endocarditis and septic shock. So the recommendations in the guidelines that urgent surgery has a class 1 recommendation in locally uncontrolled infection like abscess, pseudoaneurysm, fistula, enlarging vegetation, dehiscence of a prostatic valve, or new AV block. So please follow up the ECG for those patients, because if he starts to develop AV block, in this case you should suspect local spread of infection, and you may schedule this patient for urgent surgery. And also, surgery is indicated as a class 1 as being urgent or non-urgent according to the hemodynamic condition of the patient in case of infection by fungi or multi-resistant organism. So the endocarditis team would decide according to the status of the patient whether the surgery is urgent to be done within few days, or we can wait but before hospital discharge according to the clinical improvements of the patient. And urgent surgery has a class 2A indication in case of persistently positive blood cultures more than 1 week, or persistent sepsis as indicated by the persistence of fever or the high acute phase reactants despite appropriate antibiotic therapy and adequate control of metastatic foci, or in case of prostatic valve endocarditis caused by Staph aureus or non-Hasig gram-negative bacteria. In this case, the patient should have urgent surgery. So in case of uncontrolled infection, don't let the surgeon tell you that we should wait till the patient is afebrile in order to arrange for surgery. No, the uncontrolled infection is itself an indication for surgery. The third most common complication are the embolic complications that we should prevent. Brain and spleen are the two most frequent sites of embolism for left-sided endocarditis, while the lung, of course, is the most common for right-sided and pacemaker lead endocarditis. Sometimes even stroke is the first clinical manifestation of infective endocarditis before the classic presentation of sepsis, and this increases the morbidity and mortality. Sometimes the embolic events may be asymptomatic in nearly 50% of patients only diagnosed with non-invasive imaging, and this explains why in the video of diagnosis of infective endocarditis we mentioned that whole body imaging has a class 2B for asymptomatic patient to detect silent embolic complication, which of course may increase the urgency for surgery, and the management of patients infrequently altered due to the results of this imaging. However, CT brain usually affect decision making and outcomes according to presence or absence of strokes or intracranial hemorrhage. The embolic risk is usually the highest on the day after diagnosis and therapy initiation, but then it drops in incidence within the first 2 weeks with the antibiotic therapy if the patient is responding. And the risk factors for increased risk of embolism are the size, of course. The larger the size of vegetation, the higher the risk of embolism, and when the vegetation is mobile, the risk is higher. The location of the vegetation on the mitral valve carries a higher risk. Increasing size with the follow-up echo of the vegetation under antibiotic. Staph aureus is one of the highest bacteria for the risk of embolization, also Staph galolyticus and the Candida. Patient has history already of previous embolism, so he can have a recurrence with a higher probability. Multivalvular involvement, of course, a patient has infection on only a mitral or aortic, not as the same risk as a patient with both aortic and mitral affected, as the risk would be higher. In these cases, we should have surgical removal of potentially embolic material from the heart as a source of emboli in order to prevent new or additional embolic events. So the guidelines recommend an urgent surgery for patients with a persistent vegetation more than or equal 10 mm after one or more embolic episodes despite antibiotic therapy, and in case of vegetation more than or equal 10 mm and the patient has other indications for surgery like heart failure or unresolving infection but without embolic events, in this case you are justified to go for urgent surgery. There is a class 2B indication for urgent surgery to be considered in patients with vegetation more than or equal 10 mm but no valve dysfunction and no evidence of embolism, but the patient has low surgical risk, so why not go for surgery? There was a prospective randomized trial discussing this issue in low-risk patients. It assessed the effects of early surgery in patients with large vegetation and streptococcal endocarditis versus conservative treatment. The result is that there was no significant difference in all-cause mortality at 6 months between early surgery and conventional treatment. However, the risk of embolization was significantly reduced with early surgery, and in non-randomized observational analyses of high-risk patients, it suggested that early surgery may be beneficial in patients with a high likelihood of embolization. This explains why there is a recommendation for urgent surgery in this situation in absence of other complications, but it has a weaker evidence. And this diagram summarizes the indications of surgery in all the complications of infective endocarditis. There is only indication for emergent surgery in case of cardiogenic shock or pulmonary edema. Otherwise, the surgery is usually urgent, and in few cases it is non-urgent in case of clinically stable patient, but he should have valve surgery before hospital discharge. After we discussed the indications of surgery, let's give some hints regarding the neurological complications. First of all, unexplained fever accompanying a stroke in a patient with history of valvular heart disease should raise a suspicion, of course, for infective endocarditis complicated by embolic stroke, which may occur in about 35% of patients of infective endocarditis. Sometimes they may be silent in up to 80% of patients. The patient is completely asymptomatic and does not report any neurological symptoms, of course this increases the mortality and morbidity. It may have a clinical presentation of ischemic stroke or TIA, which are the most common presentations for neurological complication, or sometimes intracerebral or subarachnoid hemorrhage due to rupture of mycotic aneurysm. Meningitis and brain abscess are recorded in literature but less common. But of course, one of the commonest complications are the infective or mycotic cerebral aneurysm resulting from embolization into the vasa vasorum of the arterial wall, so weakening the wall at this part that may rupture, resulting in subarachnoid hemorrhage. And there are some factors increasing this risk, like Staph aureus infection, as we mentioned, the highest risk of embolization in relation to other bacteria, and of course the large size of vegetation and the mobility. Of course, early diagnosis and starting treatment are essential to prevent neurological complications, and early cardiac surgery in high-risk patients, as we mentioned the indications before, is the key to prevent embolization that may worsen the prognosis and increase the mortality. And we should know and emphasize that antithrombotic and thrombolytic therapy have no role in stroke caused by infective endocarditis, because the pathology here is completely different from ischemic stroke or, for example, embolic stroke caused by atrial fibrillation. We are not speaking here about a thrombus sending an embolus. We are speaking about a septic material coming from a vegetation on the valve. So the recommendations to diagnose neurological complication: to arrange for brain CT or MRA to detect any suspected infective cerebral aneurysm, and if there is continuous growth of this aneurysm in the follow-up imaging despite antibiotics, or it was complicated by rupture resulting in subarachnoid hemorrhage, we should arrange for neurosurgical repair or endovascular therapy. And if we compare the surgery with the endovascular therapy, the problem with surgery is that requires craniotomy, and it needs 2 weeks delay before the cardiovascular surgery, while endovascular therapy can be performed on the same day with the valvular surgery if it was urgent. But if the patient has no need for urgent valve surgery, so we are going to arrange for the endovascular treatment of this aneurysm prior to the valve surgery if there is no documented rupture. What about if the CT or MRA are negative, did not show any evidence of aneurysm, but we are still suspecting them? So we can arrange for invasive cerebral angiography using digital subtraction in order to detect the aneurysm, as it is more sensitive than CT and MRI. And in case of embolic stroke, mechanical thrombectomy may be considered in order to have a bailout therapy for this stroke if the expertise is available in a timely manner. And needless to say that the retrieved embolic material must be sent for pathology and microbiology to confirm that infective endocarditis was the cause of this embolic stroke, and is the organism the same as that present in the vegetation or a different organism necessitating changing the antibiotics. When should we arrange for the cardiac surgery after a neurological complication? Of course, if the patient had just a transient ischemic attack, cardiac surgery is indicated without any delay. But after stroke, there was a debate. Many surgeons claimed that after embolic stroke, there is a risk of hemorrhagic transformation if we perform the valvular surgery as early as possible, because we are going to use bypass machine and so needing heparin. So this heparin will result in hemorrhagic transformation. But now the recommendations of the Task Force of 2023 recommend that surgery is recommended without any delay in case of heart failure, uncontrolled infection, or persistent high embolic risk or abscess, as long as there is no coma and the presence of cerebral hemorrhage has been excluded. So go for surgery without delay, as the majority of publications showed lower risk of hemorrhagic transformation of uncomplicated ischemic lesion than the risk of recurrent embolism. So I should be afraid of recurrent embolism more than the fear from hemorrhagic transformation if the patient had early surgery. So the available evidence is go for early surgery even after stroke, in absence of coma and absence of hemorrhage. But what if the patient had already intracranial hemorrhage? In this case, we should delay the surgery by more than 1 month in order not to increase the amount and the size of hemorrhage, with frequent reassessment of the patient's clinical condition and imaging. And in case of intracranial hemorrhage and unstable clinical status due to heart failure, uncontrolled infection, or persistent high embolic risk, urgent or emergent surgery should be considered according to the likelihood of meaningful neurological outcome. So in this case, we should have a discussion within the endocarditis team with the neurologist, neurosurgeon, to decide whether this patient would benefit from the valvular surgery with good neurological outcome, or there is a bad prognosis as the patient started to have, for example, decerebrate or decorticated rigidity, so no reason to go for surgery. So in this case, we should have a discussion within the endocarditis team. And just a note, cerebral microbleeds should not postpone surgery when indicated due to lack of any association with parenchymal hemorrhage and the absence of any post-operative neurological complication. So whenever they are present, do not consider them as intracranial hemorrhage complication from infective endocarditis. No, go for your valvular surgery. And this diagram summarizes how to deal with an infective endocarditis patient complicated by stroke, and when to go for surgery and when should you delay the surgery. There is a big misunderstanding regarding the use of antithrombotic therapy for infective endocarditis. The first question, is there an indication for anticoagulation in left-sided infective endocarditis just to prevent embolic complications? Of course, the answer is no. Infective endocarditis by itself is not an indication for antithrombotics or anticoagulation, because here it will not reduce the risk of stroke, cerebrovascular hemorrhage, or mortality at 10 weeks, but it may increase the risk of cerebrovascular hemorrhage and increase the risk of rupture, mycotic aneurysm. So, the only indication to have anticoagulation is in a patient with left-sided infective endocarditis with a pre-existing indication for anticoagulation, like prostatic valve endocarditis or atrial fibrillation, in absence of any contraindications for anticoagulation. Otherwise, don't start them. You should interrupt any antiplatelet or anticoagulant therapy in presence of major bleeding, including intracranial hemorrhage. And in those with intracranial hemorrhage and a mechanical valve, the decision to reinitiate unfractionated heparin should be considered as soon as possible, but after a multidisciplinary discussion to decide whether to start them early or we should delay starting anticoagulation according to the neurological status. And if the patient is already on oral anticoagulation for a prostatic valve or atrial fibrillation and in absence of stroke, stop the oral and replace them by unfractionated or low molecular weight heparin according to the local policy with close monitoring, especially when there is a likely indication for surgery, for example, Staph aureus, which has a virulent course. I expect that sooner or later the patient would need surgery, so I don't want to wait till I stop, for example, warfarin, till the INR reaches the baseline level that the patient can go for surgery. If the patient needs urgent surgery or emergent surgery, I want to go as soon as possible without waiting for the INR to come down to the baseline. And the big no, that thrombolytic therapy is not recommended in patients with infective endocarditis per se, just for lysis of the vegetation, because some doctors may misunderstand this, and of course not recommended in embolic stroke caused by infective endocarditis. The pathology is completely different from ischemic or embolic stroke caused by, for example, atrial fibrillation. We are speaking here about a septic material. And the second most common organ to receive emboli is the spleen, as splenic infarcts are common in left-sided endocarditis in nearly 20% of patients and often to be asymptomatic. However, 5% of patients may develop splenic infarcts up to abscess, and in this case the patient has recurrent or persistent fever, severe abdominal pain, and of course the follow-up blood culture show persistent bacteremia. What are the investigations that I would ask for in this case? Of course, the most simple, abdominal ultrasound, not conclusive. Go for abdominal CT or MRI not conclusive and still there is a suspicion, go for PET CT to detect the uptake of fluorodeoxyglucose in the spleen. Then how are we going to treat it? Of course, appropriate antibiotics for the splenic infarction, although we know that the antibiotic penetration may be poor in splenic abscess due to the biogenic membrane, and in resistant case we should go for splenectomy, or in case of large abscess or even rupture, and usually it should be performed before the valve surgery in order to eradicate any metastatic foci of infection, and then go for the valve surgery, because the cardiosurgeon will tell you that I don't want reinfection of the new heart valve. So splenectomy at first, then valvular surgery after this. Some surgeons may prefer percutaneous drainage or laparoscopic surgery in patients with high surgical risk for open splenectomy. And of course, don't forget that after splenectomy, the patient should receive vaccination against the encapsulated microorganism like pneumococci, meningococci, or Haemophilus bacteria due to drop in the immunity against these encapsulated organisms. Another complication that should not be omitted are the osteoarticular related infections. Sometimes we cannot decide where was the primary infection, whether an infective endocarditis at first resulting in an emboli to the bone or to the vertebrae, or the primary infection was the osteoarticular one and then the bacteremia resulted in infection on the valve. Its incidence is nearly 6 to 8% in patients with infective endocarditis that may affect the bone, resulting in osteomyelitis, joints resulting in arthritis, or vertebral disc resulting in spondylodiscitis. And the most frequent microorganism, without thinking, of course, I would say Staph aureus, the highest risk of embolization and one of the very virulent organism beside coagulase negative staph and enterococci. So what are the investigations that you are going to ask for spondylodiscitis, for example? MRI is a gold standard, but if it is not available, you can arrange for CT, which can detect the indirect signs of spondylodiscitis, but not as accurate and sensitive as MRI. If they are not conclusive, you can arrange for PET CT. And the treatment, of course, appropriate antibiotic therapy for 4 to 6 weeks and sometimes longer, especially in patients with Staph aureus or Candida or developing epidural or perivertebral abscess. Surgery may be indicated in case of neurological deficits or severe spinal instability. And in patients with urgent indications for surgery, please do not delay the cardiac intervention or contraindicated because of infection in the spine or in the bones. Arrange for surgery to eradicate this metastatic focus and then go as soon as possible for the cardiac surgery. So the recommendation to diagnose spondylodiscitis, to arrange for MRI or PET CT in case of suspected spondylodiscitis or osteomyelitis complicating infective endocarditis. So it was a primary infection resulting in metastatic spread to the bone, or if the patient is having spondylodiscitis or septic arthritis with positive blood cultures for typical infective endocarditis microorganism, so in this case you should arrange for transthoracic or transesophageal echo to rule out infective endocarditis, because it may be the primary infection in the heart and then spreading to the bone, or the primary infection in the bone spreading to the heart. And in case of spondylodiscitis caused by Staph aureus or Candida or complicated with severe vertebral destruction or abscess, more than 6-week antibiotic therapy should be considered in this case to eradicate this infection. Then you should not forget the conduction disturbance that may occur as a complication in infective endocarditis. As we know that the AV node and his bundle lie in close proximity anatomically to the insertion of septal leaflet of the tricuspid valve, the aortic root, especially below the non-coronary and right coronary cusps, mitral valve, annulus, and so any new AV nodal conduction abnormality, even first degree AV block, may occur due to paravalvular extension from an infection like an abscess in these anatomical sites, and this is considered an indication for urgent surgery. So you should deal with new AV block the same as you deal with abscess or paravalvular leak or pseudo aneurysm. And after valve surgery, sometimes the patient may develop AV block due to, of course, the extension of infection and due to the surgical excision of the infected valve or the surrounding structure, like, for example, peri-aortic area or aortic root, so the risk of AV block is high. So the recommendation in the guidelines that if the patient is having a valve surgery for infective endocarditis and he is already having complete AV block with one of the following predictors of persistent irreversible AV block, like preoperative conduction abnormality present before surgery, Staph aureus infection, aortic root abscess, tricuspid valve involvement, or previous valvular surgery, in this case, immediate epicardial pacemaker should be considered in those patients. Do not wait till the patient comes out from surgery and then wait if the AV block will resolve or not to decide for transvenous pacemaker. No, go for epicardial pacemaker during the valve surgery. Then the last point in this video are some surgical principles related to the valve surgery for infective endocarditis. First of all, the preoperative coronary angiography. In case of a patient having aortic valve vegetation and the surgeon asks you to have coronary angiography because the patient is a male, more than 40-year-old, or a female postmenopausal, in this case, I should arrange for CT coronaries instead to minimize risk of coronary embolization, because here the vegetation is on the aortic valve. Invasive coronary angiography is recommended in any patient requiring heart surgery at high risk of coronary artery disease, but in the absence of aortic valve vegetation. Otherwise, arrange for CT coronaries. And in emergency situation, valve surgery should be done without any delay, because I am going to arrange for preoperative coronary angiography either by CT or invasive coronary angiography, because in a recent study that questions the need for cappage of non-critical lesion at the time of surgery for infective endocarditis, it suggested that concomitant intervention for a coronary may have a negative impact on the preoperative outcome because you are prolonging the time and duration of surgery. So just go for the infected valve without paying attention to the coronaries at the time being. Invasive coronary angiography may have a class 2B in case of aortic valve vegetation in patient at high risk for coronary artery disease, but of course the first recommendation is to go for CT coronaries. What about intraoperative echo? Of course it adds a lot, as it is recommended in all cases of infective endocarditis requiring surgery, because it can assess the extent of infection before the valve repair or replacement, reassess other previously uninvolved heart valves in order to decide whether they are going to need intervention or not, and determining the immediate result after putting the new valve or repairing it, and establishing a baseline for follow-up comparisons. A debatable question: are you going for valve replacement or repair? Of course, replacement is usually required for aortic endocarditis because repair is uncommon in the acute situation. Usually you excise the infected valve, but it may be performed, for example, in isolated aortic regurgitation after healed endocarditis. In case of mitral infective endocarditis, leaflets perforations with preserved free margin and chordae may be treated with just patch repair without replacing the valve in case of subacute or healed endocarditis. And in a large registry performed on mitral repair patients versus replacement, it was done in order to compare the results, but it was limited by the lack of information on the severity of infection, different patient group profiles, and significantly higher incidence of staph endocarditis in the replacement group. Therefore, valve preservation in acute endocarditis is difficult, so it should only be attempted if a durable repair is anticipated with complete eradication of the infected tissue. For example, in children, the options for valve replacement are limited, so valve repair may be necessary in children, but in adults, we may tend toward valve replacement. But if the valve is not damaged, in this case, we can think of repair, and this decision should be discussed within the endocarditis team. Another debatable question: aortic valve plus minus aortic root replacement. When the disease progresses into an extensive aortic root abscess or periannular destruction, aortic root replacement is usually required. You cannot just excise the valve leaving the infected aortic root. And in this case, the use of allograft has been preferred because it has the advantage of adapting to the irregular surface with good hemodynamic function and low thromboembolic risk in comparison to the prosthetic graft. And another debate, mechanical or bioprosthetic valve, is still not answered. But there are some features that may favor non-mechanical valve in the setting of endocarditis. For example, early surgery after a recent ischemic stroke. I want to avoid anticoagulation as much as I can to reduce the risk of hemorrhagic transformation, evidence of intracranial bleeding. Of course, I want to avoid any anticoagulation after surgery. Women of childbearing period, in this case, the bioprosthetic valve are preferred. High likelihood of prolonged mechanical circulatory support. The risk is lower with bioprosthetic valves. Advanced age or frailty. Patient may have unknown compliance to oral anticoagulation, so I should prefer bioprosthetic valve. And if I expect complicated or prolonged postoperative course, the bioprosthetic valve have a lower risk of morbidity. And don't forget the patient preference. If the patient, you discuss for him the two options with their pros and cons, and he choose bioprosthetic valve in order just to avoid anticoagulation, even if he is going to open his chest again for a new valve replacement after 10 to 15 years of mechanical degeneration, you should respect his choice because he understands and he knows what are his preference. So we have reached the end of our video today, and our take-home message that you should always be concentrating and mindful about the complication that an endocarditis patient may develop in order to arrange as early as you can for the investigations to confirm them, then arrange for surgery if indicated without any delay, because in this case the delay may increase the risk of mortality. Thank you very much for watching this video, and wait next week for the last video in the guidelines of infective endocarditis, which is the specific types of infective endocarditis.